There's patients that, they'll come up and say to me, oh, I need some PRN medication, Valium, whatever, I'm anxious. And, there's me who's worked in the public and they've seen someone have full-blown panic attacks pretty much all day. In public, they'll say, okay, you can have one tablet. But private, that took a lot of getting used to at the start. I sort of thought, hang on, what? That patient's not, like I said to the nurse, that patient's not typically like acutely anxious. Like, can we do some talk therapy? Can we do some other things perhaps? And they're like, Georgia, these are private paying patients. They're paying top dollar. We had a psychiatrist working with us last year that was charging $1,000 an hour.
So Georgia, thank you very much for joining me today on the Lived Experience podcast. And I reached out to you and you responded really quickly saying you'd love to come on, and you've shifted a few things around for us. So we thank you very much for doing that. Do you want to start off with a bit about yourself and why you wanted to jump on and share a bit about yourself on the Lived Experience podcast?
So I'm a registered mental health nurse. I currently work in a private inpatient facility. Very passionate about mental health care. Was a general nurse, but I find mental health very rewarding. And there's just so much to learn. Every day's a completely different day. Yeah, very, very passionate about mental health. So I'm studying my postgrad at the minute online with RMIT in mental health nursing, and I work as an A&M or like assistant manager in the private facility.
I've spent a bit of time in psychiatric facilities with my mum, and I knew a lot of nurses who work there very well, and they're very patient people. You have to be very, very patient to work in that environment. My mum was very frustrating for people to deal with. But so do you want to talk about the actual facilities and maybe just enlighten people about what they are for self? Because I think a lot of people have a picture in their head where, there's stray jackets and there's white walls and whatever. So maybe you want to talk about the facility where you work at and what's actually involved in and caring for people in those places.
Yeah, so it's nothing like they in the movies, even in the public setting, because I came from working there, definitely no padded walls and all of that kind of thing. But where I am in the private facility, I like to sort of, when patients call up for the pre-admission assessment and I'm trying to describe, it's more of just a home away from home, a bit of a reset. So the environment's quite casual. It's we've got like a communal area, a lounge room and a dining room and stuff. The patients have their own rooms, own bathroom. Where I work, the subacute facility, they have a rehab downstairs, so physical rehab, and upstairs we're just mental health. So the patients come and they do their inpatient programs during the day with the psychologist. Occasionally we do like music therapy and art therapy, but it's really just like a reset we find in the private setting more anyway. People that just need to get away from the stresses of home life and come to a place that just feels relaxed, really. So yeah, it's a very, very calm environment. Yeah, we just try and make it as close to what they would be at home, but just, without all those extra stresses.
And do many families come in and visit, or are there many kids who have a mum or dad in there? Because that's what I know a little bit about. So how does that work? And what are your thoughts on that sort of situation?
Yeah, there's we have visiting hours, just pretty much the same as what in a general hospital you would have. With the COVID lockdown and that kind of thing, it was very challenging because, we couldn't have people coming in and out and all of those kind of things. We don't tend to see a lot of families. I know with kids, and as you would know, it is a difficult environment sometimes for their kids to be in, and a lot of parents, this is more the private setting. Perhaps in public, when they're more acute and more unwell, they would have family around. But it's sort of dependent, really. There's some people that are sort of say, no, we'll go downstairs to the cafe and I'll see the kids there. I've just told them I'm unwell and I'm just having a bit of time out. But then sometimes people are fine with it. They're fine with having their kids up on the ward. Adult children, mostly we see, but not very rare. You see the young younger ones come through. And particularly in public, I know it was a bit challenging because sometimes we'd have patients that were, they've got history of one particular situation, a pedophile convicted. So, we do have to be very wary and very assertive of what's going on, who's on the ward in terms patient-wise, and if we're bringing young kids in and that kind of thing. So we do have to be considerate of that.
And have you worked in the public mental health facility before as well?
Yeah. So I'm up in country Victoria in a big public hospital. So I worked across a few different units because I was on the casual bank. So the adult acute unit, the extended stay unit, mother and family unit, and also age psychiatry. So I got a bit of a broad variety in public before I moved across into private. Yeah.
And do you want to tell people about what acute inpatient means? I know a little bit about it because my mum was in a regional facility in the acute area a few times. So maybe you want to describe for people, because the process of someone getting help in these facilities, because I don't think there's a lot of knowledge around it. I think people just think you get someone rocks up and picks you up and takes you there, but there's a whole process around it.
Yeah, the public, so involuntary, you get people after they've had the assessment in ED, if they are at harm to themselves or others, they would be held involuntary. And again, there's time frames for that. We try to be less restricting as we can be. And mental health tribunal, that's also another thing that I sat in quite often with patients that, they swore black and blue that there was nothing wrong. They had very little insight to how unwell they were. So they were, that's the public setting. The private is a referral based. So they obviously have to be willing to go, voluntary. And a GP or a psychiatrist or someone can refer to us, and then our psychiatrists say whether they're capable to take on the patient or not. So it is a bit of a jumping through hoop system with the private. So it can be anyway for patients to be admitted. But the public setting, they try to be as least restrictive as possible and obviously keep patients there for the minimal amount of time until they are safe enough to work out a plan from there.
Yeah, because the acute areas, because there's a couple of areas. I remember the acute areas where they have there's no electrical cords, there's no things that people can do anything to themselves. And then if they're a little bit better, they'll get moved out into another area of the facility.
We still do that in private. We still take cords longer than 30 centimetres, razors, anything at the start when we do the bag search and all of that. And it's mainly, I always say to patients that get a little bit offended in the private setting, because they're not that acutely unwell, I just sort of say it's more for everyone else on the ward. You can never sit complacent. Somebody could walk past your room and perhaps grab something and take that as an opportunity. So, and then sometimes the psychiatrist might say, look, I'm comfortable with them keeping their cords for work purposes. If someone comes into private and they still need to be doing those things, that's necessary for them. And sometimes it causes a bit more harm than a bit more disturbance probably when you do take things when it's not needed. So,
Now in the public facility, do you want to just talk about, generally for my mum, it was more, she used to get very manic. So it was more about trying to get that under control. So, mixing, changing medications, electric ECT and all this sort of stuff. So maybe just talk to people about someone is in the public system and they're in, let's say they're involuntary. Is the process where it's more, assessments and there's, changing medication, or what's the treatment, or what's the sort of, what the support they get?
Yeah, so with the ECT, that's generally involuntary as well. I have seen patients that have had to have involuntary ECT, so against their will. That's in very dire circumstances where the psychosis is quite prominent and it's ongoing for a long time. So containment and things like that. There was a patient in public that had done $20,000 worth of damage from ripping the stuff off the walls and just damage to the place. So in those circumstances, they would be considering those kind of things, because you can't 24/7 for weeks on end. It's really dangerous. And so, that's involuntary. But other than that, there is quite a few assessments within the public it's mainly containment really in the public, containment and safety, whereas the private setting is more you're tackling things on a deeper level. So yeah.
And what's your thoughts about ECT? So I know a lot about ECT. Well, I'm not a doctor, but I've experienced the effects of it with my mum. So what are your thoughts about ECT and because it's something that's not spoken about a lot. If you go to, let's say, websites like Black Dog Institute or whatever, and they have a thing on there where it's a PDF, for example, treatments for bipolar, they don't have ECT even listed as a treatment. So maybe what are your thoughts about ECT and about how maybe it's not well known or people don't really know about it?
It's sort of like, it's the last resort, definitely. And I watched your videos with you explained your mum's situation and, the side effects and all of that. So, because memory loss and some quite awful side effects come from it. So it really is for those dire circumstances where medication's failing. You wouldn't be doing it so much in young people. It's, and most people have that attitude of, oh, it's like shock therapy, like in the movies. Again, a lot of mental health, like inpatient, connotations come from the movies and stuff. So it is, I've witnessed it. I've been in theatre and I've seen the doctor give it. And it's quite confronting. When I was a student, you see the patient's body like seize up and everything, but after a few minutes, they're back out of the anaesthetic, they're recovering. I've seen it work wonders in terms of really depressed people, bedridden, that melancholic, sort of just staring at the wall, won't eat, won't do anything, won't speak. And then after 10 rounds of ECT, turn around and say, "Hi, Georgia, how are you today?" And I'm like, oh my goodness. And, and that's middle-aged to older people, where you think absolutely give it a go if that's a quality of life that they can have. Yeah, very unwell and dire circumstances, but you wouldn't be advocating. Perhaps that's why it's not so much advertised or spoken about in the public, because I think it is definitely something you should be considering as a last resort. And then you've explored all options. So, yeah, but they've got some advancements now. They're bringing out the ketamine for treatment-resistant depression. I just had an education session on it last week. And that's sort of like in the dire circumstances like ECT. That won't be available just to the general public. They will have had to have tried 2 different antidepressants and failed with both. And TMS has to have already been trialled beforehand, but they've done the clinical trials and comparison rates compared to all the other antidepressants on the market. That was miles ahead.
Okay. So TMS is the magnetic.
Transcranial. Yeah, so I'm trained to give that, and that's just a tapping, really. The patient doesn't have to go under anaesthetic, but it feels like a bit of an irritating tapping on the brain, on the frontal cortex. So they are doing that, but they'll do that in conjunction with a medication as well. So we give a lot of that in the private setting. At my hospital, we don't do ECT, but yeah, TMS, there's a fair bit of evidence to say it does do something, but of course you'd try that before, doing ECT, and I'll have all those side effects, because there's not really any side effects to TMS. So
and how does that work? Like, what's the theory behind it?
So it's just, they don't really know the nitty gritty, but it's the magnetic impulse that they're triggering within the frontal cortex, sometimes other parts of the brain, but that's the most common on the left side, just stimulates activity in the brain. Beyond that, there still isn't too much research as to how well the actual, the nitty gritty of it, basically, because I did the training with Epworth Innovation for Mental Health, and they're in Melbourne. They train most of the people around the state in TMS. It's becoming very popular in nearly most private facilities. The machine itself costs an arm and a leg. And but again, in terms of that, they're only really just talking about deep brain stimulation a lot more, because that's using MRI. I don't know too much about that, but basically TMS does this much of the brain, goes that far in, and then it's really just touching the surface. So there's still a lot of development going on in terms of the magnetic stimulation within the brain and that kind of thing. And Parkinson's, it's used quite often to treat Parkinson's, TMS is. So yeah.
And what about, you mentioned before ketamine. Do you want to talk more about that? Because obviously psychedelics, I think, just been approved in
Yeah.
Australia. So maybe you want to talk about how that's sort of going to filter into what you do or.
So the S-ketamine is basically, they're using it a lot lately for pain in lots of different forms as ketamine infusions, which they do a lot downstairs in the rehab for persistent ongoing pain and stuff, and also wafer form. But this particular one is just for mood and treatment-resistant depression. So it's a nasal spray, which we have to be trained in to give. It's just like a Beckinase or something. It's just literally like 1, 2, but we have to monitor the patient for an hour and a half post because their blood pressure can drop significantly and they can have some dissociative symptoms. So it's just giving that bit of extra reassurance. It's not it is not much of a workup as there is with the psilocybin and the MDMA, because when I was asking the guy about it, I said, so this is the psychedelic movement now, is it? And he said, oh, that's still a couple of months off, and even still the workup for that, the staff time, all of that kind of thing, because it is very significant in terms of mind altering and all of that kind of thing. The environment has to be under certain conditions and stuff like that. So the ketamine will be much more accessible within a private facility, but it can only be given in certain clinics because, they're just trialing it at the minute. So they're not going to bring it out in public hospitals because it's going to be a very minority group that do the criteria fit with them. So basically, they would have had to try 2 antidepressants, TMS, and basically. So I said with the statistics of it being so effective, because it actually, with the synapses on the brain, it increases the amount in the brain. Whereas your normal medication that are on the market at the minute with your antidepressants, your SSRIs, all of those kind of things that boost serotonin and that kind of thing. This is actually, it's going above and beyond. So I said, how come we can't just give that to a patient to start off with? They come in really bad depression. He said, money, that's the crux of things really in the private system. He said, it's going to have to prevent patients that are coming back for recurrent admissions and they've spent X amount of dollars, because this S-ketamine treatment would be about $20,000 for, it runs across 6 months. They do it twice a week at the start and then once a week twice a week for 8 weeks, once a week for another 8 weeks, and then maybe once a month it peters out. But he said about 20,000. So it won't just be something that you can just walk in off the street or, I'm having this bad depression. It's just going to be very strict, the criteria. Yeah.
And the studies and the research show that it's effective, or obviously it is because it's in this thing, but it's really effective, is it all?
Yeah, and the relapse rate was significantly lower. So these are people too, they would have had to have had chronic suicidal ideation for about 2 years as well. Mm-hmm. They're unable to work. They're constantly having to come back in for admissions and that kind of thing. So we're talking on that level of debilitating depression.
And how do you see these sort of treatments, the newer ones, working with, let's say, schizophrenia and bipolar, which how do you see, because from my knowledge with medication with bipolar, there's obviously lithium and stuff, which is still used, and there's obviously newer ones, but all those newer ones, there's always risks, there might be issues with the heart and you have to have scans every 6 months, all this sort of stuff. So how do you see what new treatments or what do you see from that sort of developments, and how would that apply to maybe schizophrenia and bipolar?
Yeah, I don't know too much about how they would go with those kind of illnesses, but I would say it's because you've got clozapine and all of those kind of drugs, which, they have to be monitored pretty closely. Your lithium levels obviously have to be monitored. So I'm not too educated on that just yet, but I would say that that's probably not going to be the main focus at the start. He's definitely emphasized the fact that it will be just treatment-resistant depression at this stage. Yeah, I don't know the studies about whether that would be effective for that kind of thing. But knowing from my personal experience, patients that with schizophrenia and that they've had their medication that they've been on for X amount of years for the majority of their life, and without that, if they've been non-compliant or something,
Mhm.
they ended up very, very unwell very quickly, which maybe perhaps with your mum, with meds, she had to take it. It wasn't just like, people with depression that skip a pill a day and then, they pick up back up. It's like that's what's kept them, in those instances has kept people out of jail when I work in public, and people have been on clozapine. And they've said, this is a harsh drug, but this is what's kept person B out of, jail. So
Yeah.
think it's like, why would you interfere with that? I mean, obviously, yeah, if there were side effects and stuff that the doctor had said, no, that patient, it's far riskier to stay on this. Perhaps let's try these other options. It's sort of like if it ain't broke, don't fix it sort of thing. That's how I would approach that. Yeah.
Absolutely. And yeah, we have clozapine. Yeah, no, she was on clozapine for a while and she had to get monitored for the heart because that's what the issue was with heart and all that. But yeah, adherence is a big problem. Adherence was you think it's easy to take a medicine every day, but it's not, and that causes a lot of issues. So
yeah, and there's so many side effects to them as well. That's why we get people coming in quite often for readmissions, because a side effect will just pop up. They might be like, oh, I'm trying to conceive, or I've been eating too much, I've gained X amount of weight.
Yeah.
They just pop up. So it's like, it's not that people you say, oh, nah, I just couldn't be bothered taking my meds. There are these, life happens. Yeah.
And with what's your thoughts about what can be done more to support people in the community with this sort of stuff? Because prevention is always, or keeping people well at home is better than having them come into facilities. So what sort of things can be put in place, or what's actually reasonable to be put in place for people maybe with more serious issues?
Yep. So we've got community teams. There are community mental health workers who they generally work the hours of 9 to 5, and they'll go around and be keeping an eye on people. But the system is just pushed, as everyone could probably understand. You'd have to meet a certain criteria of like unwell or not live with anyone or have any supports to monitor your medication usage. You can't just, which is a shame, because there are some people that would just benefit from someone to go around and say, hey, how are you going with your meds? Stuff, but it really, they are pushed, the community teams, and they're always we're getting patients call up and say, oh, such and such hasn't come around, and people get really agitated about that. And I've known people that work in community where they can't just finish at 5 o'clock because, such and such has called and said, oh, I'm going through a crisis right now. And, without being the CAT team, they're sort of the next one. So it is difficult from what I've heard, the community can be. But yeah, I mean, every system is it's pushed. So yeah, it's.
Where do you think resources can be allocated better? Because, there's always a lot of money, mental health is sort of something that the community, so governments like to get behind it because it's a good feeling thing for them. So where do you think money can be allocated better for the best use?
In terms of like a community sense, or
just in general, where do you think money can be allocated better? Yeah.
Yeah. I'd say, well, particularly in my setting, the staffing, the private system. I mean, I can have up to 1 to 9 patients, which is not ideal. We had a meeting with the guy from the union the other day, and I didn't quite realise, with things like going on strike and all of that kind of thing, the level of seriousness of taking industrial action, and, you could be threatened with jail time and fines and all that kind of thing. And I don't know, I felt a bit naive, but I just sort of said, where's the humanity in this? I mean, I don't get breaks. Like that's, the harsh reality of it. And that's fine. I mean, as long as I get 5 minutes to sit down in a shift. But like last night, for instance, I was the only nurse on. We had to transfer a patient out to a public hospital because they became delusional and psychotic. It doesn't happen that often in my ward, because obviously they come in voluntary and semi-well, but it was quite difficult. Nursing students, lucky for them, they were able to monitor this patient, keep her safe, who was voicing a lot of suicidal stuff like that. And so, and then she ended up absconding. So I got out of work like 2 hours later than the normal finish time. But we had the meeting with the union guy, and I just sort of said, how do, private paying these big names, it's like how do they feel knowing that, we can work 1 to 9 patients sometimes, and the acuity level too. Mental health, people often quite have the misconception that, you just sit down, talk to the patient about ways to overcome depression and stuff. It's like, or you get self-harmers quite often, you get, anything can happen in the blink of an eye. And so I said, how can they do this? And they just sort of said, because of you guys, because you've just got that, you'll look after the patients, like you won't arc up, you won't, and, I sort of felt a bit like, is that really just the answer to all of it, but at the same time, I just do my best that I can each day. And at times it's quite stressful knowing that I could risk like my registration if something were to go wrong and I'm the only nurse on that, you just have to be very smart, very flexible, leave a paper trail all the time. I'm always documenting on email things to management. But I suppose staffing, funding, again, our patients in the private setting have to have about 3 hours of engagement a day, whether that's group therapy. So they can't just come and have a holiday because like sometimes, people might have that idea perhaps, and they come in and they're not engaging, and the government, the private organisation gets audited and won't pay the hospital for that. So there's always issues with funding, or if we want a patient to be seen by the pain specialist because he's downstairs in the rehab section, they can't fund that. And I'm just looking at the person as a whole person and all the issues they have that they need to support their mental health. And again, it just comes down to the dollar. So I used to get quite sort of negative and upset about it, but you just do the best you can with what you can. So there's money could be spent on the ground level basically instead of perhaps on a government level.
So more people doing the nurse. So let's say more people doing, let's say, psychiatric nursing, for example, is obviously a key. What about more, obviously in the public facility? Obviously, there's always never enough beds. They always say that. So is there more facilities, or what else is needed?
Well, like for instance, we're a 30-bed ward and we only have 7 patients now because it's based on the psychiatrist. So I'm told that there's quite a shortage of psychiatrists in Victoria, perhaps Australia-wide. And like we've only got 1 psychiatrist working at the minute, and he can only take on 5 or 6 at a time because he also admits patients at other hospitals or in private practice. Not pointing the finger at the psychiatrist because obviously, he's got lots of other things going on. So that's quite difficult because when I've spoken to friends or family or just anyone and they've said, oh, God, we've got somebody in our family that's desperate for a bed in a mental health ward. And then there's me that I go to work, and it's, as nurses, we try our best. We've got all these referrals like come in left, right and center, and we give them to the psychiatrist and they say, sorry, I'm full, or sorry, that patient is a bit too behavioural or acute for what I can take on at the minute. So in my case, it's definitely beds, but it's really difficult to see. And then when patients and family members come in, they're like, oh, wow, like this is not, everyone's busting to get into a facility, but there's no one. So I don't really know the answer to that. I suppose maybe more doctors, but funding for doctors, I don't know. Quite often we get doctors that come as locums too. So they'll come for maybe a month. And then they'll move on to the next hospital because they get paid quite a lot for that, I'm told, because I sort of questioned that and I said, how come they can't stay? But apparently, there's big bucks in travel psychiatry, like moving around the state and all of that kind of thing. So that's difficult as well. There's quite a lot that money could be spent on. So I wouldn't even know where the major point to start with would be.
Well, the shortage of psychologists is a big problem because for someone to become a qualified psychologist, there's a lot of study involved. Most of the time they have to do a master's as well. And then let's say they're 25 or 26. It's very hard for a 26-year-old to tell to a 45-year-old or a 50-year-old about life or anything in general. So what about counsellors more? Have you ever, what are your thoughts about counsellors or getting more, let's say, older people into maybe becoming counsellors? So I interviewed a lady called Kerry Atherton, and she's really full with her trauma counselling and stuff. But when she deals with patients, she's dealing with people like 40, 45. And because she's that age as well, it's way more of a better experience where she's had to deal with younger people before. It's always been a bit harder.
Yeah, definitely. And there's so many, in terms of holistic care, so many different therapies. I'm doing some courses with Center of Healing and stuff at the minute, and they look at embodied processing and all of those kind of things. That psychotherapy is not for everyone in terms of just sitting down to a psychologist and talking about their problems. There's a lot more deeply rooted stuff that can be dealt with, but that's not really advertised, or that's still classified as very alternative. And, and there's so many therapists ever since I became part of that community while I was doing those courses. Yeah, people that have so much knowledge, life experience, all that kind of thing, but they're not a clinical psychologist. So there are heaps of people around. I mean, I've got friends that do Reiki and all those kind of things as well. And yeah, there's so much potential in the world, but there's, in terms of like the qualified position or whatever, it's very scarce. So yeah,
I think people sort of think they need to go to a psychologist when they could probably go to a trauma counselor or just a counselor who's got a lot of life experience who might be just as beneficial for them. But they sort of probably think, I need to get the referral from the GP for 10 sessions to go to a psychologist. And not going to, because I don't think counsellors can get that, which is what I've been told. Apparently you can't get the counselling sessions on the rebate thing. Psychologists,
and definitely, and in private setting, we deal with a lot of people that become quite heavily addicted to prescription medication. So you've got your psychiatrist that quite often will prescribe a heap of meds, which some of them very necessary, but some, perhaps not. And there's patients that, they'll come up and say to me, I need some PRN medication, Valium, whatever, I'm anxious. And, there's me who's worked in the public and they've seen someone have full-blown panic attacks pretty much all day in public. They'll say, okay, you can have one tablet of them. But private, that took a lot of getting used to at the start. I sort of thought, hang on, what? That patient's not, like I said to the nurse, that patient's not typically like acutely anxious. Like, can we do some talk therapy? Can we do some other things perhaps? And they're like, Georgia, these are private paying patients. They're paying top dollar. We had a psychiatrist working with us last year that was charging $1,000 an hour.
$1,000 an hour.
Yeah, and he was is over prescribing quite a lot. It doesn't work for the same mob, but yeah, that was difficult to sort of, for me, in terms of my values and what I believe is effective and not effective. And I've seen people become addicted and having to withdraw from benzos or opioids. It's awful. But then there's, if they want it, they go and see a psychiatrist, and the psychiatrist charges all this money. And,
why can't they charge that money? Is it because it's just a shortage at the moment with the market, or why can they charge that much? Because that's a pretty obscene rate, $1,000 an hour to do.
I'm not too sure what. Yeah, that's that's not in my scope, but I know that he'll prescribe patients sort of, I won't say what they want, but, quite often there's situations where I think, could you have perhaps discuss some alternate options? There's a patient that she's on lithium and major depression, but she was only in her early 20s, lovely, lovely girl. She's been back with us a few times and prescribed lithium twice a day. I think it was like 900 milligrams. And even still, I had to push for blood tests for lithium levels. This is the particular psychiatrist that was charging that much money. And she ended up discharging with us. I gave her lots of information, leaflets on lithium toxicity, and documented. That's all I can do. I advised her of the side effects and the dangers of it, this level that the doctor's prescribing. And then she ended up in ED after she left us a few weeks later with lithium toxicity. So, and that's, I sort of questioned it, you get good at talking to doctors without being the bossy nurse, what do I know sort of thing. But I approached it with that sort of stance. And then he just sort of said, we need to stabilize her mood, her severe depression, before we go into all the alternate talk therapy or whatever else it's going to work. She's just that bad at the minute. If we can get to that level, then she'll be able to. And see, I'd rather do it the other way around, try everything else and then resort to meds like that. But yeah, it's
it's a good point illustrating that. From your experience, I'm going to ask you some generalized questions. This is from my experience, but I've always had really good experience with the psych nurses. I've always think they've been far nicer and more educational and receptive to me than what psychiatrists or doctors have with my mum, and that's just, I've dealt with a small pool, but that's my experience in general. Do you think that psychiatrists or doctors realize the actual impact of their treatment, or they consider the long-term impacts to the family unit? Because I don't think, from my experience, they don't. I think they just want to get that person better or whatever as quick as possible. And I think they really lack some care around that decision or the decisions they make, because that lithium one's a prime example. Like, he might just be a bad egg, but it's not, I don't think it'd be an uncommon thing.
Yeah, and even in general nursing, I think just the whole medical hospital field, you get that because the doctor will come review the patient for 5 minutes. Well, that was in general nursing. In mental health, they try to spend about an hour with them once a week. But then we deal with the after effects of it. It's a 24-hour business, you see. So quite often they'll come and have made their decision or said what they've got to say, and then it's us nurses that have to advocate for the patient, deal with family situations, and be on the phone to them. There's been a few times when family members have called me and they've, I'm apologising because the doctor hasn't communicated to them as he promised or whatever he or she has promised. And then they've sort of been like, oh, thank God for you. Like, when they're crying on the phone to me, and it's sort of like, oh, like at the start of my nursing career, I thought I'm just the nurse. But then I sort of realised over time, you're not just a nurse. You're the center of all communication. So it is very challenging at times, but I do love it. It's very rewarding in that sense. So yeah, you're looking at the whole picture of the person really, as opposed to just the doctor's one or two sense that they've got to add, or any disciplinary for that matter, whether it's a pain specialist or whatever. And quite often they don't communicate. So like if there's a pain specialist that comes and he prescribes all these things, all these benzos or pain relief, which we've just worked our guts out to get the patient off for like 1 or 2 weeks, like weaned down, not just taken off completely. And then the pain specialist has just come for 5 minutes. And because I'm the only nurse on the ward, I'm too busy running around doing other stuff. So I don't really get to say, oh, hey, by the way, Dr. Blah, blah, this patient also has a history of substance abuse or addiction. And then boom, the patient's on a whole heap of meds again. And then I'm the one that has to deal with it and sort of say, hang on, come on, we've worked so hard to get here. And then the doctor can just undo it all in 1 minute. So
yeah, from my experience, the communication has been extremely poor and the sharing of history has been extremely poor. And I just don't understand how that can be the case when everything's supposed to be documented and written down, and then yet a new person gets involved and they can't read a file or they can't look it up. I find it very, very hard to fathom with the amount of bureaucracy there is in Australia with a lot of things and records and kept and the stuff, that the communication and lack of actually knowing patient history is
definitely. I mean, even turning a couple of pages and you can find out so much about a patient. So that's why I try to educate the students. And the first few days when they're like, oh, everyone's settled on the ward, they don't really understand mental health, and there's no dramas going on, everything's cool, this is easy. And I'm like, go sit down and have a read of the patient's file. There might be some referrals from a couple of years back, and then they're reading through and they're like, oh my God, this person, like, they're just presenting as, chill and all good. And I'm like, you do a bit of reading, bit of research on your patient, and it definitely gives you a bigger picture. So yeah, as a nurse, you are sort of that person that has to do all of that, because otherwise no one else will. Too many people stick their fingers in the pie is what we usually say. And then that's when things can get really messy. Yeah. And then patients have said to me before, thank God for you, Georgia, because you get stuff done. And I'm like, well, I care. Yeah.
And where do you think doctors need to get better, or psychiatrists need to get better? Like, we've talked about communication, obviously, and I personally think the mannerisms with patients, I think, is a bit, well, with family members, that's from my experience. But where do you think they should need to get better, or that training needs to improve?
A few areas, like the overprescribing is a big one. The alternate therapies, or exploring a few of those. Sometimes I think, does this doctor have some kind of a cut in a big pharma?
That's a good point.
Yeah, but because I think, why wouldn't you have suggested this before resorting to that medication? So that's why I'm like, But yeah, the mannerisms, like you say, it's so easy just to give that patient that little bit of extra time. Everyone just wants to be listened to, I've learned, and I always say to the nursing students, you don't have to go in with advice, or aside from the fact that's not really our scope of practice, that's more the psychologist. But people want to be listened to. And it's amazing how much, if you just give them that couple of extra minutes, or just don't try and talk at them, ask them, include them in the plan. We do a collaborative care plan at the start of every admission, where us as nurses sit down and work out just dot points of the goals that they want to work on during the admission. And it can be quite as simple as that. That would have avoided a lot of situations where the patient has become agitated or upset just because the doctors come in, said their 2 cents and then walked out. So, but at the same time, I mean, you can't, there's situations where the doctor obviously might be pressed for time or whatever, but yeah.
And why do you think it's such a big issue in Australia, let's say mental illness and mental health in general? Because it's a lucky country, yes, in a way, there's good GDP, people earn good money. But why do you think it's such an issue from your perspective?
Just I think on a community level, there needs to be more support groups. I mean, obviously just advocacy and awareness in general, you get all that with your social media and stuff, we all know that. But there's either the acutely unwell that go to ED and end up involuntary, or there's people that wait months and months with their referral to come in for a private inpatient stay. And in between that, there's the rest of Australia, and there's going to see the GP and getting your referral to go and see a psychologist for the 10 visits, and you can't get in. So you think, oh, blow that. And then a situation escalates, mental health becomes terrible, it deteriorates quite quickly. Just something in the middle. That's why I think, I don't know how you could address such a vast population of people, but yeah, on those levels with preventative work and perhaps support groups. For instance, there's a patient at the minute with a brain injury, and he's trying really hard to find a support group for, you'd think in Melbourne in general there would be a whole heap of ABI support groups, but there's only 1 or 2 or 3 in the major hospitals, the public hospitals, that offer day programs and support groups. And I was sort of have you looked on, social media, Facebook and stuff? And this guy's a really intelligent guy for his brain injury. he's doing so well. And, there's people like that that are actively seeking, and they're still not finding the resources. So yeah, it's not easy. It's sort of just you're sick or you're not sick. And then there's just too many people that, they've got struggling with mental issues or life stresses. And yeah, it has to become a serious problem before they can get access to help.
Yeah, I don't think an awareness. Yeah, you're right. I don't think awareness is an issue. I think we're beyond awareness now. It's more integrating it and putting better things in place, and in community care and different things, especially young people as well. I think young people have got to really deal with a lot of issues now. And I think if they don't resolve those issues when they're younger, it will escalate. As you said in your message to me, which I want to ask you about now, is about young people and what more can be done for that in regards from your perspective. So
I didn't realize until I started doing a bit of research in that area that I think this was overseas, but in the UK, I was surprised to know that 50% of all mental illnesses will start festering before the age of 14 or something like that. And I was like, what? You don't think of a kid or a teenager as mentally ill. You sort of just think that it's something that happens one day when you're an adult and life just gets too much, and that's that. But it's all of this that's occurring within childhood and adolescence. And I just remember from my school days, there's health as a subject or psychology, but no sort of coping mechanisms. I remember once, I think maybe in Year 12 study camp, to prepare you for the stresses of VCE, it was just going out to a lake and, doing team activities. No sort of coping mechanisms like breath work, meditation, all that. I'm told now that from my friends that work in teaching that they do sort of touch on meditation and those kind of things, but I don't remember a lot of all of, coping mechanisms about how to deal with life. You certainly don't get any kind of classes on, managing finances. Yeah, just general life stuff. And I was like, wow, there is such a deficit. And any wonder, patients, they come in after they've just graduated high school and they're already severely suicidal. And I'm like, thinking your life hasn't even begun, but at the same time it has. They've just been in a schoolyard and been studying, and that's that. But there's been a whole heap of childhood trauma or whatever that's occurred, and that's not being dealt with. And then all of a sudden, here you go, adult life, deal with it. So yeah, and I'm quite passionate about it. I find with my younger patients at work, just making them feel heard. A lot of them come from families where they're quite strict, or there's been trauma there, particularly now with the pronouns and all of that, and being identified as whatever it is that you will choose to be identified with. That's still quite a new age concept. I didn't learn that at uni, and now we're dealing with that quite a lot in the units. Patients are getting quite triggered or emotional because somebody has said, oh, girls come for the medication, when there's a person that's been born female that identifies as a they, them, has been quite emotional and upset. One particular case, that girl had grown up in a family where they would tell her to go to her room and lock her away every time they had guests over and stuff. So there was significant trauma there, and they were 18 or something, and they just were chronic suicidal ideation, self-harm and all of that. It wasn't until they got better throughout treatment and being with us for a few weeks that I was able just to give them the time that years and years their family hadn't. And that's when I was like, wow, there is such a lack of support for young people out there. If we can do some things earlier, get in before life just happens and they become an adult and then thrown in the deep end, because that clearly is very, very difficult for a lot of people, a lot of the population.
Yeah, it's a tough one because, high school can be pretty brutal for a kid, like, let's say if they're 14, 12, 16, whatever, to go and seek or speak to someone about their problems is not a really easy thing. But it's very, very important, because I personally think a lot of people's issues come from trauma or from unresolved trauma, whether it be childhood events or whatever. And people flippantly say, oh, well, everyone had a bad childhood or whatever, but it's not. There's a lot of serious stuff that goes on that people don't resolve, and then it escalates into something where they might drink every week into excess, or they might do drugs, or they might not be a risk taker, which affects them career-wise or something like that. And it can all be generally related back to an event or something like that. And it's just over years it builds up. And then, as you said, maybe 40 years old, you might have a breakdown or something, and they end in care. And then that's when they deal with it. But they've had, 20 years or 25 years of this unnecessary pain. And the problem is a lot of people don't have the, it's not courage, but let's say the ability to take that step to go and get.
Yeah, I think they even know that they're capable of speaking up. But because you go from being under the care of your parents and then being at school, teachers telling you what to do, and then out into the workforce one day and getting a job, and you're always told what to do. So to be able to have that autonomy over your own self and know that you can, I'll say that was the case for me, definitely, because I grew up quite strict family and stuff. And, that I adore my family, but then I went into the workforce and dealing with other situations that led to anxiety and all of those kind of things. I just felt like a bit sort of stuck. And now that I'm aware, I work in the health profession, the mental health, how much there is out there, that's only because I've been exposed to it. So that's why I put so much time and care into the younger patients that have just come out of high school and life's hell. And, that's not to discredit them. It is, you've not experienced the world, but you've experienced a very controlled part of your life that you're unaware of just how much you can accomplish and achieve and the help that you can get. So I find it very empowering when I can speak to them on that level and just sort of say, things will get better, and you be real with them and just sort of say, I don't know when it will, but you've got options. You've got as opposed to just saying something generic like the world's your oyster, or, go on, because you haven't been given that autonomy. So that's why if there's school programs and stuff in high school that they can be exposed to about their self-awareness, that would be massive. Self-awareness is something that a lot of us don't have, or we try to navigate through our early 20s. And I think that comes from childhood traumas and not feeling accepted and bullying and whatever. Yeah. Just definite, they need coping mechanisms and all those kind of things earlier.
Yeah, I think there's a lot of mentality still, unfortunately, where a lot of, let's say, men in particular will be really dismissive if someone says, childhood trauma or something like that, just get over it or whatever. That's the sort of mentality that I think there's still a lot of. But as you and I know, that if you don't deal with that sort of stuff, it can manifest into just a lot of major problems. And people where they might get to 45 and goes, Jesus, my life sort of sucks. And it's related back to something they should have, maybe at the age of 16 or 17 that's happened or whatever, and they should have got some help for. And I think that's a big, important message. So how do you think we reach, let's say, young men in particular, because I think young men are probably going to be less inclined to talk, or especially because their social circle might make fun of them if they find out or something like that. So what do you see that's being done, or what do you think would help reach those people?
It's grabbing them in that opportunity where I feel like with high school, that's because once you're out into the world, you're not gonna get involved in any kind of therapy and stuff willingly, because it's not been offered. That's why that would be a major thing, just grabbing the opportunity to educate them. I think if you can do it in sort of a way that, for example, like a school program, if they made the males, perhaps write down or speak about something that they'd want to hear in a life crisis, or doing it in an anonymous way too, as well, because I think it's all could be all stuff that people are just too scared to talk about it. Everyone's got mental health problems in their life, but it's just so funny that just everyone just feels so, because it's so stigmatized, they can't just talk about it openly. So I feel like in an anonymous way, in an environment like a school or something, perhaps write down suggestions of things that you would want to hear if you were feeling not necessarily suicidal, but if you were feeling at your lowest point, what things would help to hear from your family or from a friend, or what do you wish you could hear, or something like that, where it's and then all your answers or something get made public, because that's, you're forcing people to put their voice out in a way that's not going to make, like, they're not going to be made fun of or something. Yeah, definitely, because they are resistive groups, and that's the way that they've been trained to feel. They're males, harden up, like, get on with life. And that's, I see that now with all my older men patients. They don't want a bar of it, which is really sad, because it's like there's stuff that can be done, and I can't go in and lecture them and just sort of say, have you tried this therapy, have you tried that, because that's just not what we're told as kids, to do all these alternative holistic care. So yeah, I think getting to the crux of it earlier in school settings or something, so it doesn't become like a learned behavior that we're just meant to get on with life.
Yeah, well, it's a big problem, because it's the biggest killer, under 40 for men. And the problem is that the governments, it's such a short-term cycle that it's harder for them to sort of, it's a 10-year plan, because, you might want to, how do you really, you got to do these studies from, let's say, from someone's 14 to maybe follow them till they're 30, and what could you've done? So it's a long-term thinking that needs to be done.
By that time, there's already damage has been done for a person, so yeah, definitely there's no use saying, oh, we could do this or we should do this. It's sort of, that's why I think in my job, where stressful as it is sometimes, it's like, just do something every day, that's, I could get angry at the whole system and say, I need an extra staff member to do this and stuff. Whereas it's just like, just give your absolute all to a patient in a moment. And, that's why I do stuff like I'll print off resources for patients, and I'll do all this extra stuff that I don't need to do. But if I've got the time, of course I will, because otherwise, we can just say, oh yeah, that could be a great therapy for this person or that person. It's like, just do it. And I guess that's where, nurses are we practice that a lot, just getting on with making the movement now, as opposed to the big grand scheme of things, because it feels like that will just carry out. And then by that time, something could have happened, and particularly too with suicidal patients and stuff like that. That's why that's sort of perhaps given me a bit more urgency with acting on situations. And you don't want to think, oh, what could I have done or what should I have done? But I'm talking on a larger scale. I don't really know. It's not my expertise, but yeah,
And how do you look after yourself with doing your job?
Well, that's been a practice that's taken quite a few years to get used to. Because
people forget about it. That's the reason why I asked that, George, because I always met very, very patient. The psych nurses are extremely patient. I think, geez, I couldn't be that patient all the time. So I think it must be maybe something innate in you'd have to love it to do it. So how do you look after yourself? Because you deal with some confronting and stories and situations. So how do you look after yourself?
So sometimes I've had to get better at it. That's the thing. Because when I started my nursing career, it was like I burn the candle at both ends and, commit to too much in the outside world, and also commit to my patients so much so that you find yourself doing way too much for other people in your private life. So that's why that's taken its toll over the years. But only now, I'm 28, am I really able to sort of say, like, use your downtime to go for a walk, or just you might have to say no to seeing a friend or family member or something. But you get smarter with just being able to rest and actually taking that opportunity, because otherwise you can't give your all to the patients. But, I've always said in my private life, if everything was to be chaos, I can go to work and I'll be so calm and collected. It's sort of weird. I don't know. They make that joke. They say that psych nurses are the craziest of them all. But at my job, I'm very focused. So it's a work in progress, but I am getting better at just taking a moment to chill in my life outside of work. So,
and do you guys get offered any help, or what do they do to look after you?
There's debriefs and stuff if a situation was to occur that's quite traumatic. We had a patient last year who went out on day leave and suicided, and we did the root cause analysis and everything afterwards. It was ongoing for months. Didn't go to coroners or anything, because we'd done everything we could to have made sure that, or not predicted that this situation would happen. He was not presenting in a suicidal way, denied it. So all of that, but we got a bit of a debrief after that. But when I say a bit, like one session where we all sat down with the psychiatrist, the treating team, hospital management, and we were told that we'd have some more debriefs, but that just didn't eventuate. But on a ward level, we all just sort of looked out for each other, and on a big scale, it seems that things don't get done. So that's why we look after each other on the ward. We've got a good community and stuff like that. So yeah, they do offer those things, but nothing. You sort of have to be looking for extra help if you want extra help, it's kind of tough. But I like, for instance, I sign up to heaps of education things online. So they always offer talks on compassion fatigue and how to manage that.
It's a good, compassion fatigue. That's a good phrase I haven't heard before. It makes sense.
Yeah.
So maybe do you want to talk a little bit about that?
Yeah, it's basically not letting your job get in the way, or not letting your stress get in the way of the way that you present yourself and the amount of care that you can give. Because I have seen that with older nurses that, they're close to retirement. This is the same in any occupation, and they're quite dismissive and sort of make the patients feel a bit, put off. But yeah, I think that's perhaps, they should be getting like back in the day, maybe they didn't get quite as much of that. Like, I know my dad's in the police force, and they definitely didn't. That's come advanced in terms of debriefing in care, because you didn't get that sort of follow-up back in the day. So that took its toll on mental health and stuff like that. So perhaps, hopefully there's a shift, like when my generation become older nurses, where we won't be quite as burnt out. Because I've seen the burnt out nurses try to be there for patients. And I've always thought, oh God, I hope that it's time to retire. It's time to go into something else, because that would just be awful. Like, I see that the strain it puts on the patients, and it's not really necessary. I always think, well, why are you a nurse? But it's not very common that you do see that, though, particularly mental health nursing. I think because it's such a specialized area, unless you genuinely did have a strong sense of compassion, you wouldn't really pursue it. Because I've got friends in general nursing that, it's sort of one or the other. They're very much like, oh, I couldn't do what you do. Like, how do you manage it? And still to this day, people are like, oh, psych nursing. And I'm like, yeah, but with general nursing, I feel like I take my hat off to them. I'd feel a bit, out of place if I was back on a general ward now, because I've gotten so skilled at mental health and talking to mental health patients. So I think, that's probably why you don't see it too much, because if you're in mental health as a whole, you want to be there. You want to have a very caring attitude. And
what would you do to improve the system from your perspective? What would you do if you could fix certain things? There are some things that stand out to you that could be done a lot better, or what do you think it needs to focus on?
I don't know. I feel like it's such a typical nurse answer to say everything, but the hardest thing is perhaps knowing that a patient's circumstance or situation could be completely different if there was I'll speak in the private system, if the funding was there for, if we had a GP that could come up more often, or a pain specialist that could come up more often to review the patient while they're staying with us, but they just can't because of a money perspective. It's like, well, I'm not getting funded to go up to that mental health ward. And I'm just like, oh, it's the collaboration of everything. I think that's in a nutshell, sorry, what I would say. When there's resources, it's like, let's use them. Come on, don't, but in a public sense, it's been a while since I've worked in the public system. I wouldn't even know where to start with them. But that's the major thing I'm tackling with in the private sense. So and the empty beds too. That's the thing that really worries me or concerns me, is knowing that there's people desperate, clutching on the outside, for a bed or some safety or, mental stability. And then there's vacant beds in my ward. So I don't know how they can fix that. I'm not an expert on finances and economics and stuff, but yeah.
I was going to say as well, what are some future developments that you see coming into your field? Like you mentioned some treatments before. What are some things that you can see down the path that might come in place, that maybe some new technology, or is there some new methodology, or what's some new things that you think should be implemented that they might be coming upon the horizon? Because we don't really know too much about the brain still. Let's say bipolar disorder, they know ECT works, but they don't know why it works still.
Yep.
So, there's a lot of guesswork still in the field, right? So what's some stuff that you can see in the future from your perspective that you think will make a big impact, or some developments that you think might come across?
I don't really know, because like you say, the brain, there's just so much that we still do not know. I mean, there's obviously the whole psychedelic movement coming, and then
that's the big one obviously the big one everyone knows about. Do you think it's going to make as much impact as what they say it is, or what are your perspectives on it?
I think it's the whole everything that's new that gets introduced. I think you mentioned before, it takes a period of time to actually be established and developed. They say that the approval of those medicines, but we won't be seeing them in the hospital until I feel perhaps next year even. I think somebody mentioned because the rollout process for all of these treatments and things, they take time. So it's hard to sort of gauge, how far things are going to develop and how fast and that kind of thing. But honestly, the brain, there's just so much that we don't know. And it's just obviously not a thing where you go and you have a broken leg and you go and get fixed. It's still just being I really don't know what would be next, I suppose, but definitely if there's more community groups and stuff that can get patients to live above the line, as opposed to, mental health still very much viewed, I think, as something that has to escalate before something serious happens or a situation gets explored. So, whether that's been stigma or whatever over the years, mental health is just a thing that people they'll address later down the path. So I would hope that developments in the next few years are more proactive. Yeah, definitely. And don't know how they're going to address it on a wide scheme.
Yeah, well, I think there's a couple of things, which is the 10-session thing. I think you're having to go to the GP to get a referral to a psychologist, which you might be able to get into 3 months. And as we know that, like, you know, you're not going to click with the psychologist first time. And then not having counsellors being able to even get involved in that sort of thing, I think is a pretty big,
yeah.
bit of a rort, but.
Yeah, if there's more, like I only discovered there's a website, Someone Health or something, where they're bulk billed psychologists, and there's a very extensive list, and they actually have a paragraph about them and the topics they're specialised in, and that's all in one place. And I think there's another big one that people use, but you know, those kind of things aren't really explored when you go to a GP, and if you're a bit resistive of getting treatment and you just sort of say, oh, I think I should see a psychologist, the doctor there is just going to type up a referral to any old place down the road and just say, okay, there you go. You know, the general public don't really know unless they go researching online about psychologists and stuff. So yeah, definitely all the people out there use them for all the things that they're educated in, and it doesn't, you know, necessarily have to be a psychologist, like you're saying. That would be fantastic if, you know, all these people that do alternative therapies, if they can make themselves known, and, you know, whether that's social media or whatever, or somehow in the community, like come out of your little burrows, because we need some more goodness in the world.
Yeah. No, well, I find it like, you know, talking to a lot of people with a lot of life experience, you know, 50, you know, and they become a qualified counsellor, but they can't participate or get any sort of government funding. So they've obviously do it on their own bat and stuff. But yeah, I just think there's a lot of people out there who could probably transition into this sort of area where it's needed. But it's very, very hard, and, you know, the government won't assist in any sort of way when these people do a really good service for their you know, clients. But they're not technically, you know, psychologists, so they can't get any sort of government assistance. And I think it's a bit of a shame.
Definitely. And that was just reminding me, with the nursing degree bachelor, there is one unit for mental health. So that's why it took me a while to actually figure out that I was passionate about mental health and wanted to work in mental health, because...
Now, I find that strange, because there'd be a lot of presentations to the ED, a lot of mental health cases. And my girlfriend's a nurse in an ED. So there's a lot of mental health. And as you said, you have to go there first to get an assessment to then be made an acute, regardless if you've got 40 years of history, you have to go and do the same process. So it's amazing that there's only one unit on it.
Yeah, definitely, because that's why I try to grab the students' attention when they come for their placement with us on the ward. And I've just recently made up some booklets for them, because the information that the uni gives you, the booklets, is so dull. And you know, they come to us and they think, oh, well, there's no patient kicking off with schizophrenia, or there's, you know, a couple of depressed people sitting there that I'll just go and talk to, I suppose. And they just sort of come like, mental health's not the area for me. And then straight away, then we've lost them. That's a whole bunch of people that we could have in their industry, because it's just one unit. So that's why I made up these booklets, because I'm quite a visual person, with all their experiences and education, holistic stuff, you know, not just here's your psych meds, like learn them, or, you know, CBT, blah, blah, blah. I've put in a bit of effort, which, you know, I'm not getting paid any extra for that, but I do that because I want to bring people interested in the area. And it, just like therapists and all of those type of things, you know, they're not paid the same as a psychologist, whatever. They're making so much movement and discussion in mental health and interest in it. So, yeah.
Well, you'd think the curriculum would be changed, because obviously they're crying out for more people in the field, and they're saying, well, you know, we can put all it's serious to the government and whatever. And as you said, there's only one unit on it, when it's such a, you know.
UK and England and stuff, they do the actual course in mental health nursing. They don't have to do your RN.
Yep. Yeah. So, I think, it's probably still a bit of bureaucracy here, and they've got a very slow, unfortunately, sometimes I get the sense of. And I was going to say, from your perspective, from dealing with a lot of patients, what are things that you think, if let's say there was something you could change back in their past, it's very hard to say, but is there something where, like, you think, if only this person had this intervention at this age, they wouldn't be here? Or what are some things that you think could be done at an earlier stage, retrospectively looking at the patients you deal with? What are some things that would have made a big impact to them, and maybe in stopping them from developing the issues as they got older?
Yeah, I think that's why the school thing I'm really passionate about, because this situations where they're suicidal or self-harmers, or they've come from a damaging family environment where, someone in the family is abusive or whatever's happened, if they could learn some coping mechanisms to get through that, because there's no way that we can, say you'll eradicate family violence or whatever, or if they had learned some coping skills to know that they're okay, they're still a human, they're valid, even if they're yelled at as a kid or they're exposed to some kind of trauma, they can make a change. Yeah, coping mechanism or something along those lines, because that's what I always see, and patients that come into us and they've just come out of high school and they're like, oh God, so here I go, I've got to get a job now. I've just studied my ass off, and there's no lust for life. I've kind of always thought perhaps if there was more resources put out of adult hobbies that you can have or something, because it is it's a hard world like we live in now with work and inflation and all that kind of thing. Of course sometimes it's a bit mundane, and you take that and mix it with someone that's come from family trauma. There's the person that they face a lot of mental illness and suicidal ideation. So I think those sorts of things would be helpful. Coping mechanisms being taught in school, stronger self-awareness, as opposed to, just telling kids they've got to go to school and then get a job and then move on with life, because there's no room for movement once you become unwell. It's sort of, they become quite suicidal very quickly. And it's just like, if those sort of things were put in place more, maybe.
Absolutely. Now, I've taken more than enough of your time, and thank you very much for shifting your shift around to do this. Really appreciate it. Is there anything else you want to say before we finish up today, or?
No. Thank you for your time. I really appreciate it, and I love what you're doing.
Thank you.
Because it's helping us mental health nurses to get the voice out there.
Well, when you said you were a nurse, I was like, I want to talk to your show, because I've got a lot of respect for mental health nurses. I always have. They were always good to me, so I've always it's a tough job as well. Like, it's not an easy job. I understand nursing in general is not an easy job for people, but especially you've got to be a particular type of person. I know my mum, when she was manic, was so difficult to deal with that it would have driven me. I couldn't deal with her, so it would have been that frustrating. But they were so calm and empathetic. They're really, really good people. Everyone I've met as a psych nurse is a good person. There's no one who's there for the money or there because they don't want to be. They're all there because they want to be, and it's underpaid. And it's a very important service to the community. It's unfortunately like, I remember with nurses, you have, let's say, union labourers paid all this obscene money, and everyone says, oh, the nurses should get a better union. But it's like, you can't strike, or you can't not there. You care about your patients and what you do. You're just not going to strike for a week or protest through the city.
Definitely. And it's just like, and you see all the CMFU people that, they went on the strike, and because of, I don't know, the pay or whatever it is.
They wanted a pay rise.
All these macho men, holding up on the West Gate and stuff. And then it's like, oh man, I'm just going to go to work and look after my patients. And to be honest, that is, you have to love it, I suppose, because I do enjoy going and knowing that I'm making a difference. Sometimes I feel like, how it sounds a bit cheesy, but like, how can I have this job that I just love? Like I get to be myself, I get to just be my complete, utter, genuine self and care for people. Because in high school I was always like the caring friend and stuff like that. And now I get paid to do it. So that's why I'm like, it's awesome, Yeah,
and I think it's a detriment to how much you guys are paid, unfortunately, because you guys just love it, and I know you're not going to strike for a week, or nurses aren't just going to just walk off the job. And it's criminal that a CFMEU labourer is paid more than a teacher or a nurse. And the arrogance from their side will be, they should get a better union, but you just can't. You're not going to not go to your job for a week or take a full day off, and it's just not in the nurses or teachers' nature. Not in your nature to do it. So I think it's an unfortunate thing, and that they're just lucky that people who do that job love the job, and regardless of the money, almost in a way, you'd be doing it anyway.
Yeah, definitely. Yeah, but no, I always say I don't know what I'd be if I wasn't a nurse. So, and that's the thing. Like, I've worked in hospitality. I've had quite so difficult jobs, but that's why I have a lot of appreciation for it now. Some older burnt out nurses, they're like, oh, this patient, they're so, taking up my time. And then I just think, oh, this is so much better than being yelled at for making a coffee not warm enough or something. It's
for sure.
effective. That's why, I'm super glad that I worked in all those difficult occupations and hospital and stuff where it's really hard. But then, I did nursing placement, and now I can talk to people when they're suicidal and make them feel good again. And to me, that's like, oh, this is amazing. That's why sometimes I pinch myself, and I'm not just taking the mickey when I say, oh, I feel too lucky to have my job. That's why, because I've worked from the ground and had those difficult jobs, and now I get genuinely appreciated, which is super lovely.
Yeah, no, you guys do a fantastic job, and the community is very lucky to have you guys. I just hope you guys can get paid more, all nurses in general, especially psych nurses, but for what you guys do.
Mm-hmm. Yeah, definitely. But a bit by bit, and with awareness like what you're doing too, that's making everyone realise. So we just get on with it.
No worries. Thank you very much, George. I appreciate your time.
No worries. Thank you for having me.